Hello, and welcome to Module 2.2, the Patient Protection and Affordable Care Act. This module is meant to help community health workers and other professionals better understand the Affordable Care Act and help their clients understand and access health insurance options newly available to them. Today I will give a brief introduction to the ACA, discuss why the ACA was developed, discuss the goals of the ACA, how the ACA has affected healthcare cost, changes under the ACA and insurance coverage policy, new insurance coverage options under the ACA, and possible changes in ACA implementation since original passage in 2010. The Patient Protection and Affordable Care Act, or the ACA, was enacted by the 111th Congress and signed into law by then President Barack Obama in 2010. It was slightly amended by the Healthcare and Education Reconciliation Act of 2010. It is a comprehensive federal health reform, often known as Obamacare. It's far-reaching and affects many parts of the health sector. This module will focus mainly on its impact on health insurance coverage. Since passage, the law has been challenged on multiple occasions. A major challenge was heard by the Supreme Court in 2012 under the National Federation of Independent Business versus Sebelius. The decision upheld most of the law, but struck down state obligations to expand Medicaid, which we will address later in the presentation. There have also been multiple legislative challenges, also known as repeal and replace attempts, since 2010, but none have been signed into law. There have been some changes in how parts of the law are implemented, but for now, the ACA remains the law of the land. The ACA was developed in response to numerous issues. One was the high uninsured rate in the United States. An estimated 44 million non-elderly adults were uninsured in 2013, the year before many of the ACA's important provisions began. By the time most provisions of the ACA came into force in 2017, the number of uninsured had dropped to 27.4 million. Among those who remain uninsured, costs continue to be the main reason. Also, 45% of uninsured are people who are categorically ineligible for ACA programs. This includes some immigrant groups and some people living in states that did not choose to expand Medicaid. Another reason for the law was a need to curb the high cost of healthcare in the United States. Healthcare accounted for almost 18% of U.S. GDP in 2010. This is much higher than other similar countries, but also resulted in poor health outcomes in our industrialized peers. And these poor health outcomes are marked by racial and ethnic health disparities. The ACA was developed to address these and many other issues, without changing the overall structure of the American healthcare system, in which most adults under 65 receive employer-sponsored health insurance. The law also supported innovative medical care delivery methods designed to lower costs of healthcare overall. It increased emphasis on prevention in the healthcare system, such as measures as eliminating out-of-pocket costs for many screening services like mammograms and colorectal cancer screenings. Another goal was to make affordable health insurance available to more people. The law created marketplaces that allowed consumers to purchase individual health insurance plans and subsidize these plans with premium tax credits that lowered costs for those with incomes between 100% and 400% of the federal poverty level. Finally, the ACA expanded the Medicaid program to cover adults with incomes below 138% of the federal poverty level. However, as I mentioned, due to the 2012 Supreme Court case, the decision to expand was left to the states. The ACA's provisions to address the cost of healthcare is not going to be the focus of the presentation. What we wanted to emphasize is that this is a wide-ranging law. For example, this is a picture of the text of the law in hard copy. Cost controls under the ACA included a move to value-based reimbursement, which changed the way that healthcare providers are reimbursed for their services. It led to greater federal oversight of private health insurance companies and created provisions for testing cost savings innovations at the state and federal level. The law also reduced out-of-pocket prescription costs for seniors by closing the gap in coverage known as the Medicare donut-hole. There are also important changes in insurance coverage and eligibility under the law. The ACA allows young people to stay on their parents' health insurance plans up to age 26. It prevents insurers from using pre-existing conditions as a reason to deny coverage or charge higher premiums. The law also prohibits lifetime caps on insurance spending and introduces penalties for employers with over 50 full-time employees who fail to provide health care coverage. Small businesses with up to 50 employees have no mandate to provide insurance, but the law created tax credits for those small businesses that choose to do so. The ACA also improves the comprehensiveness of healthcare plans. By 2014, individual and small employer health plans must include 10 essential health benefits. These include ambulatory patient services, like outpatient care that you get without being admitted to a hospital, emergency services, hospitalizations like surgery and overnight stays, pregnancy, maternity, and newborn care, both before and after birth, mental health and substance use disorder services, including behavioral health treatment, including counseling and psychotherapy. Plans must also cover prescription drugs, rehabilitative and habilitative services and devices, or services and devices that help people with injuries, disabilities, or chronic conditions gain or recover mental and physical skills, laboratory services, preventive and wellness services and chronic disease management, pediatric services, including oral and vision care. However, adult dental and vision coverage are not included under the essential health benefits. In order to address the complexity of the healthcare system and help consumers navigate through changes in their insurance options, the law also provided for in-person help through Enrollment Assisters. These individuals receive training and certification in the exchange used by their respective states, including Medicaid enrollment. The law provided funding for states to contract with local organizations and agencies to provide enrollment assistance, as well as education and outreach around coverage options. Independent organizations can also have employees trained as certified application counselors. This allows organizations such as healthcare facilities, federally qualified health centers, and community organizations to provide enrollment assistance to their clients and patients. FQHCs, which provide healthcare for underserved populations, receive separate federal funding for CAC programs. Insurance agents can also be certified to sell insurance on the exchanges, but their participation varies by state. One of the largest elements of the ACA is Medicaid Expansion. As passed, the ACA required states to expand Medicaid to all adults with incomes under 138% of the federal poverty level. Medicaid has traditionally been jointly funded by the federal government and the states. Under the ACA, the federal government provided 100% of the cost of coverage for the expanded Medicaid population to the states in 2014. This declined gradually to plateau at 90% match in 2020. As I mentioned earlier, the Supreme Court decision allowed states to choose whether to expand Medicaid and therefore whether they would take advantage of this additional funding for their Medicaid programs. To understand Medicaid expansion under the ACA, it's also important to consider what traditional Medicaid looks like. It's a state-federal partnership and generally follows federal guidelines with some state-by-state variation. The federal government provides a share of Medicaid costs varying by state from 50% to 73% of overall Medicaid expenses, which is lower than the match for expanded Medicaid. Importantly, traditional Medicaid provided coverage to people with low incomes who also fell into specific groups: elderly people, people with disabilities, minor children, and their caregivers. These groups of Medicaid recipients are still reimbursed at the traditional rate. Many states who expanded Medicaid found a growth in their Medicaid rolls, not only of people who are newly eligible for expanded Medicaid, but also those who had previously been eligible but unenrolled, which is known as a welcome mat effect. To date, 36 states and the District of Columbia have expanded Medicaid, and 14 have not. Prior to the ACA, Individuals who did not receive employer-sponsored insurance had difficulty obtaining private health insurance, even at moderate incomes. For example, it was difficult for people who were self-employed or who had employers who did not offer coverage. The ACA mandated the creation of online health benefit exchanges. These could be either facilitated by the state, or states could use the federal exchange at healthcare.gov. Individuals and families can compare and purchase qualified health plans, or QHPs, through their state's exchange. If you're unsure of what exchange your state uses, you can visit healthcare.gov to be directed to the correct site. If you are interested in more information on assisting clients through this process, there are modules in this series about enrolling in both private and public health insurance plans. Another way that the law made private insurance more affordable was through income-based premium tax credits. These are available to households between 100% and 400% of the federal poverty level who do not have affordable employer-sponsored health care available to them. These tax credits can be used to reduce monthly premiums or be claimed as a credit on annual tax returns. However, the plan must be purchased through a health benefit exchange to receive tax credits. When helping consumers, it's important to be aware that scams have cropped up around the country, with websites that copy state exchanges and try to lure people into buying substandard plans without tax credits. Also, because not every state expanded Medicaid, this created a gap in eligibility that has not been resolved. Individuals in non-expansion states who make under 100% of the federal poverty level and are not eligible for their state's Medicaid program are not eligible for tax credits to purchase insurance on the exchange. Health insurance plans are also made more affordable by cost-sharing reductions. These limits on out-of-pocket expenses such as copays, deductibles, and prescriptions, and are based on income. However, this amount does not include premium payments. The ACA also introduced a requirement that all U.S. citizens and legally present residents have health coverage beginning in 2014. This is referred to as the individual mandate. Coverage is reported on federal tax returns and could result in penalties based on income, with penalty amounts increasing each year. However, the federal tax law passed in 2017 zeroed out the penalty to become effective in 2019. So, while the individual mandate is still technically part of the law, there is no penalty for not having coverage. While the law has remained in place despite attempts at repeal or dismantling by other means, some changes have taken place. Of course, the removal of the individual mandate tax penalty is one. The federal government has also reduced funding for navigators or sisters in states using the federal exchanges, reduced advertising funds for exchanges, and shortened open enrollment periods in which people can enroll in or change health insurance plans. There's also been a rise in premiums for plans available on the exchanges in many states. Another important change is state Medicaid waivers that change how Medicaid expansion is implemented in different states. While the ACA is unpopular in some more conservative states, the decision not to expand means that federal match dollars are left on the table. An Urban Institute study found that the 17 states that did not expand Medicaid will lose out on $331 billion in federal match funding between 2014 and 2022, $66 billion in Texas alone. In response, some states have taken advantage of 1115 waivers. Part of the Social Security Act, 1115 waivers have been used prior to the ACA to allow states to implement demonstration projects that allow them to implement Medicaid in ways differently than under federal guidelines. These waivers can be used in many different ways, but recently they've been used in several states to expand Medicaid with more restrictive terms than otherwise dictated under the ACA. This allows access to Medicaid match funding and provides coverage for more state residents but makes the decision to expand more politically palatable. For example, this was used in Arkansas to use Medicaid dollars to provide private health insurance to individuals rather than a traditional Medicaid plan. Some waivers have included more stringent requirements and reporting for participants, such as managing health savings accounts, paying monthly premiums, work or community service requirements, and lockout periods for noncompliance with these. Kentucky and Arkansas have had their waivers blocked in federal court. Kentucky's plan received thousands of public comments in opposition to the changes and has been blocked before implementation. Arkansas was the first state to implement work requirements, and in the first few months lost 18,000 of 62,000 Medicaid members subject to the requirements. Their program allowed people who lost coverage to re-enroll at the beginning of the calendar year in 2019, but only 11% did so. While these two state programs have been blocked, they are both currently under appeal, and several other states have received approval for similar programs. The future of the ACA remains politically charged. The polling has shown that popular approval has increased over time. 53% of people now view the law favorably, as opposed to 40% who view it unfavorably, with the difference largely explained by political affiliation. Moreover, many of the law's provisions are viewed much more favorably than the overall legislation. For example, allowing young adults to remain on their parents' plans and health insurance exchanges have over 80% favorability. The least popular provision, the individual mandate, has been effectively eliminated. While the ACA is still in place and affecting many areas of healthcare, there are still changes that may occur in the future. At the time of this recording, legal challenges are working their way towards the Supreme Court. There also may be administrative steps to change rules or funding for various provisions. There may even be a call for more expansive Medicare for All type programs. Staying up to date on developments nationally and in your state can allow you to better assist your clients in obtaining the healthcare coverage and care that they need. National organizations like the Kaiser Family Foundation, as well as national and local press coverage, are all great resources. Thank you for your time, and please check out the other modules in this series.